in the primary care home. Before I turn things over to our presenter today, I'm going to let everyone know about asking questions. So we do welcome your questions and have some time set aside at the end of the webinar this morning to take those questions. So if you could type those into the questions pane on your GoToWebinar control panel, that is the best way. Everyone is on mute, so we won't be able to hear you and you won't be able to ask your questions. But if you type them as they come up for you during today's presentation, I will organize those and then I will read them aloud for you to our presenter and for her to answer. I also want to let everybody know that we're going to have 2 opportunities for you to participate in the webinar today via a poll and offering some feedback to our presenter. So make sure you've had your coffee or tea this morning and be on alert because we're going to be asking you to participate in a poll, and we hope that some of you out there will do so. The one question that I can actually anticipate everyone has is about the slides for today's webinar, and they are already available in PDF format on the Institute website, which is www.pcpci.org. All of you attending today will actually get emailed the link from GoToWebinar later on today or tomorrow with a link to the recording of the webinar and those slides. So you can wait to get that or visit the website later today and take a look at those. This webinar is hosted by the Patient-Centered Primary Care Institute, which is a public-private partnership launched late last year to offer technical assistance to practices working towards primary care home transformation. We are currently winding down a series of learning collaboratives where we partner technical assistance folks with primary care practices working towards the primary care home model. We have a website, which I mentioned earlier, which is where we house our library of previously recorded webinars, and then also contains registration for future webinars, and there will be some online learning modules added in the coming months. The Oregon Health Authority PCPCH program is who we're working with to form the Institute. The PCPCH model is defined by 6 core attributes, each with standards that practices attest to become recognized as a primary care home by the state. You can read more information about the standards at primarycarehome.oregon.gov. That's their website. And then I also feel it's important to announce that the 2014 PCPCH standards are available, as is the technical assistance guide or the technical specifications for those standards. So for those of you who are recognized and needing to reattest or looking to become recognized, those are really important documents you can find on the PCPCH program website. So we're going to go ahead and turn things over to Stacy to get started with our webinar this morning. Stacy is the Director of Medicare Quality Services at Acumentra Health. In her role, she leads the Medicare Project on Care Transitions, including the No Place Like Home campaign, which is a statewide website. We'll be looking at some of the resources available on that site today for providers to help them reduce hospital readmissions and improve care transitions. Welcome, Stacy, and we'd love for you to go ahead and get started.
Thanks so much, Kate. I did exactly what you told me not to. I double-clicked. It's
okay. You're going to be okay. Oh, there you go. We're in business, but you didn't click ahead a million slides, so I think you're good.
Kate coached me yesterday not to double-click because I'd click ahead a slide, and sure enough, that's exactly what I did. Welcome to all of you, and I'm so glad that you are willing to join us this morning. Our objectives are to identify typical transition communication failures when a patient transfers across settings, list effective strategies as a primary care home that a primary care home can use to improve care transitions, and translate the best practices into meeting the PCPCH standards for specialized care transitions and referral and specialty care coordination. In some ways, I feel like I'm preaching to the choir with this presentation, as you already understand why coordinated care transitions are so very important. Your clinics would be the ones I might be going to ask for best practices if I were gathering them to share with others. So please share your ideas as we go along so that we can learn from each other. So this is the first standard we'll be addressing. This is 4.E.0, and this is the newest standard. It's specialized care transitions. you need to have a written agreement with your usual hospital provider. It's a must-have, and it's a no point. I always think that's really interesting. PCPCI website has a really excellent letter that we have linked to into the presentation. I think Kate put it up on the website. It really does a really good job of starting you out and thinking about what that kind of agreement with a provider would look like. It's written for pediatrics, but it can be modified for anyone. It defines the roles and responsibilities of each provider, how communication will occur back and forth between the providers and the time frame. I think that's really important. And it identifies the pertinent information and follow-up. Effective care transitions take much more than a letter of agreement, and I'm sure you know that. It requires that you build the process to support the patient through the transition, and that you build the process to communicate with each other. I like these two pictures because they always help me remember that it really is a partnership problem. Patients are touched by so many health care providers, not just hospitals, not just primary care, not just home health or SNFs, but there's a myriad of providers, and it really is a partnership problem. Every transition in care has two sides. Every time somebody moves from one setting to another or is touched by one setting from another, there are two sides. Just like every hospital readmission begins with a hospital discharge. And this really, it just shows communication back and forth. Isolated medical information is not safe medical management. And it's inevitably, we need to share that information. So some common fallacies about care transition. It's a one-time task. Once I do this, I've got it figured out. Or one size fits all. One system will help support every patient. My favorite is everyone is clear on their roles and responsibilities. We all know what we're doing, right? Medication reconciliation has been taken care of by the sending provider. And you'll hear me use that term, sending provider and receiving provider, or sender and receiver. It's exactly what it sounds like. Everyone has access to the information they need. We know that's getting better with health information exchanges, but until all those linkages are made, everyone does not have access to the information they need. So it's all about communication. We know that patients and families are often the only source of information in a care transition. We also know that patients and families are not typically an accurate source of information regarding events during another setting of care, particularly hospitalizations. There's a report from 2010 out of the Archives of Internal Medicine that said most hospitalized patients, about 82%, could not accurately name the physician responsible for their care. And almost half of the patients didn't even know their diagnosis or why they were admitted. Of physicians, 67% thought the patients knew their name. 77% of the doctors thought the patients understood their diagnosis, or at least somewhat well. And 98% of the physicians thought they had discussed their patients' fears and anxieties with them, while only 54 patients thought they did. So I think that's a really good example of patients, particularly when they're hospitalized, they're scared, they're sick, they're overwhelmed, they're tired, and they have all these different people coming at them. And if you are getting a patient in your clinic who has been hospitalized, you need to know they really didn't get it while they were in there, and they need your reinforcement. And I think that's the biggest role that primary care medical homes can play is to work with physicians or their patients as they come out to understand what happened in the hospital, to keep them from coming out, or wherever else they're going, to keep them from having a poor outcome of care. We know that EMRs are often not compatible. There's no follow-up appointment scheduled with primary care, or it's too far out when somebody is discharged from the hospital. Sometimes even with SNFs, that happens as well. Discharge or transfer plan is not timely or complete. That's probably the biggest complaint I hear from physician offices across the state, is if they knew about a patient being admitted to a hospital, or if they received a transfer plan or discharge plan within a timely manner, then they could do a much better job with care transitions. Another big issue is there's no emergency plan, including a telephone number for whom the patient should call first. You know, people are often sent out of hospitals with a plan, but they have no idea if they get into trouble who they should call first. Rather than calling primary care, they end up afraid and back in the emergency room. So this is your first polling question. How long after a patient discharges from the hospital before your clinic typically receives a discharge plan?
All right, everyone, this is your morning test. We're hoping that you can answer this question. We'll give everyone a couple more minutes because we know folks are still waking up. It's still kind of early. All right, let's get those answers in. All right, we're going to go ahead and close the poll. And here are your results.
Thank you, Kate. So it looks like 48 hours or less is the most frequent answer. I would say that's really great, because just recently I was in Southern Oregon and I heard from a provider they're lucky if they can get a discharge plan within 3 days after discharge. That would be a good day for them. So I think that this is an example of how you've worked with your providers to try and get that information turned around faster. If you can get that information in your hands in 48 hours or less, you can be that person who is that emergency contact. You can be the provider that can provide the follow-up care. But when you don't have access to that information, it's impossible to know what's even happened. So I think that's fabulous. Thank you. Okay. Some of the best practices that I've seen along the way. Develop a plan for communicating with the hospital or sending provider. Again, that communication agreement, the letter that is posted on the website, is an excellent start. You have to find a way to communicate early to be successful. One of the clinics I talked to, they've dedicated a phone line for the discharge planners to contact their office to get quicker access. It's called the back line. And they've also determined specifically what information the hospital will send to the primary care provider and how long after discharge. Again, this is in that letter example. One of the other things you want to consider is determine how you will communicate. Will you use secure messaging? That's directed to a dedicated person at the office, and that's really important that it's a dedicated person at the office. We know that if it comes to your office and it's not, the hospital sent a fax and it's not listed to somebody in particular, it's easier for things to get missed or misfiled. Or will you use some other form of health information exchange? I was talking to OHSU recently, and they were discussing, a particular physician up there was discussing secure messaging. And you know, they're beginning to see so many emails and secure messaging that coordinating those is going to be the next step in their plan. How do we triage those secure messages? So once again, it's not a once you fix this problem, it's always fixed. It's continuous. It seems that as we add more and more options, it means there's more and more things that you have to coordinate and figure out how best to structure that. One of the other interesting things, I was in Eugene, and they use a system where their ER physician or their sending provider, actually for really complex patients, they were testing where they were doing a verbal handoff physician to physician. And I know, or provider to primary care provider to sending provider. And I know that that seems like it would be very difficult, but for those really complex people, They were using this with hotspotting patients who were showing up frequently in the emergency room and observation. They found this was really effective to reduce that bounce back. And they were getting some really good results with it. And the emergency room providers seemed really weak. I actually got to sit in a meeting with emergency room providers and clinics, and the emergency room providers really felt like it was a much better system, and so did the providers. And so that's one of the things you could consider is that verbal handoff, sending provider to receiving provider. Ask your patients to bring the discharge plan and the educational materials they received for their follow-up visit. One of the other things that we're hearing is that I don't know what my patients were told. I wasn't given the same information they were. So asking them to remember one more thing on their visit, and that is to bring those so that you have an opportunity to see what they were told. And that way you're all on the same page. And support the discharge plan. And what that really means is if it says, if their discharge plan, what they received says, call your primary care when you gain 2 pounds in 2 days, you must have a process built to deal with those calls efficiently. If patients are calling in because that's what their discharge plan says, but there's nobody on your end that catches those because they don't know that that's what they're being told to do, then we can't support that discharge plan. This is a pretty typical form. You've seen these. There are several of these out there. PCPCI has 4 or 5 of them posted as well. But this is what I mean by supporting your discharge plan. If this is what your patients have been told as they transition from one care setting to another and are being seen in an ambulatory setting, if you receive this and you know what they're being told and you can help support that, and where they say call your physician, nurse coordinator, or home health nurse, and they've listed that, those need to be updated as their care proceeds along as well. So it's really helpful to have that. And again, you can find that on the pcpci.org for both, I think it's diabetes, asthma, CHF, and COPD. These forms have been around for 15 years plus. My first experience was with an asthma management plan for children. And many of them, one of the things that I like is that many of them have been adapted and translated, and they've been tested for low literacy. And those are all very important elements of these forms. Here's another example. This came from the University of North Carolina Health Literacy Program, and they have a variety of forms there that have all been tested for low literacy if you need something specific for that. And if your patient didn't get a form like this, you should consider giving it. If they came out of a hospital or came out of a skilled nursing facility and they have a existing condition that this would be helpful, you should consider giving them one. Forms like these are not just for the hospital discharge. They should be and are used across all settings of care. I just spoke with Avamere Nursing Home and Signature Home Health, and they're piloting these forms along with a modified LACE tool and a health diary they've developed in SNFs and home health patients. And as a part of that pilot, they're sharing the information with the patient's primary care as they move out of those settings. And they're finding some really good results, keeping people from bouncing back into both skilled nursing care and keeping people from bouncing into the emergency room and back into the hospital, simply by providing these kinds of forms along with the other pieces and communicating across the continuum of care. Okay. So some other best practices we've collected along the way are identify early in the process the date the patient is likely to be discharged. I just read an article and it was talking about physician offices or healthcare should be treated like the airport as far as moving patients along. And while I don't necessarily want healthcare to be treated like the typical airport, I really like the idea of, look, we know one of the things we talked about was scheduling. We know the average length of stays for most illnesses. Most hospitals have a pretty good idea how long somebody will stay if they have heart failure or COPD, and if they're a Medicare patient or if they're dual eligible, how long they'll stay. So the idea is that if they come in on Tuesday and you know your average length of stay for these patients is 2.8 days, then you should begin communicating on Tuesday when they're going to discharge and connecting with the primary care. And I thought that was a really great take-home. Consider open access for appointment scheduling. My imagine is that many of you already do that. Keeping a spot open, though, a few days after you believe a patient will be discharged is really a great way to handle some of these really complex patients. We hear across the state that in many cases when somebody discharges from the hospital, they have trouble getting into primary care. I don't imagine this is with your offices, but in many cases they have trouble seeing their primary care physician before 3 weeks post-discharge. And that we know is much too long. You might consider designating a call-in period when patients can call in and talk with their primary care provider. So that would look like this. Call-in lines, you would instruct your patients, call-in lines are open from 8 to 9 a.m. and you can call this number and reach your provider directly. Call if you have any questions or if you have reached a yellow or red area on your emergency plan, and we'll discuss your concern and identify the best action for you. Actively encourage your patients and family to call into the primary care provider for any health problems they see. If you can teach patients and caregivers to trust their guts, you're likely to head off many of the problems that will result in them ending up in the emergency room or back in the hospital. Let them know it's okay to call about things that just don't seem right, whether that's physically, emotionally, or mentally with the patient. So this is your second opportunity to chat with us. What does your clinic do to get patients into the office within a few days after discharge? And you can use the chat box for your responses, and Kate suggested that you chat to me so that I can see them.
Stacey, there was someone who just had a couple comments that maybe you could speak to. I'm just going to read some of what I received. So the discharge plan may be sent to the primary care physician, but it gets scanned to medical records, and the provider doesn't see it until the patient comes in, or for some other reason the provider views it. And medications are often changed in the hospital. Medication reconciliation very delayed or not really done. These questions are from, or comments, I guess, are from a nurse care manager. How can we get past these pieces? How to get, primary care physicians' attention?
Yeah, I think that those are all really great questions. As far as when the discharge plan comes in and gets scanned, like I say, one of the clinics I talked to, they designated a specific person that their job was not only to get them into the process and get them scanned, but their job is to actually get them in front of the primary care provider. And I think that that's a big piece of it. There's so much paper that comes in and out of your offices, even in a paperless system. And there's so much information crossing over. I think somebody has to be the designated person, excuse me, to get that information in front of the primary care providers. And then a system set up where the primary care provider has, well, first off, time to take a look at the discharge plans, but also the role and the responsibility is that they will review them that day. That'll help a lot when you identify that this is a high-risk patient for readmission or a really complex patient, and you know them better than the hospital does. You know what their literacy level is. You know what their compliance level is. You've been seeing these patients. And that'll help you get them in sooner. They may have their first discharge appointment or appointment with their primary care provider, follow-up appointment, in 10 days. But if you know this patient and your provider has had a chance to look at it and say, we really need to get them back in, then that's the opportunity, that discharge plan. What do you do to get that information into right in front of the discharge or the primary care provider? What is being effectively done out in the community?
So I got a lot of comments into the questions, so I'll sort of read some of them off. One person said our medical assistants call and talk to patients. Another said we have designated same-day appointments that can be used for transitions of care or other urgent needs. Another said they have an arrangement with the local hospital to call the clinic care manager with any emergency department or hospital discharge that requires follow-up within 3 to 4 days. And then the care manager then follows up and connects the patient with the right resources and the time frame needed. Another person shared that they have a care coordination team that receives hospital and ER discharge summaries and contacts patients within 2 days. And then yet another person said discharge summaries are directed to our triage nurse who communicates with the primary care physician regarding the best next step and timing of phone calls to the patient with an invitation to visit the clinic. Some other people commented that they hold same-day appointments for these kinds of situations. Another shared they call the patient within 48 hours if they get the report in time and offer the soonest appointment that's available with their physician or someone on call, many times able to give them a same-day appointment, and depending on the situation, may ask their physician to double book or extend their schedule so that someone could be seen. Still another person shared that they encourage patients to communicate with them via MyChart. They have same-day appointments to get patients in, and if they know that there's a patient in the hospital, they access their records through Care Everywhere to monitor their status. And then a nurse on the patient's team will call them within 72 hours of discharge to check on status and answer any questions on medications. Still another person, just a couple more, said they have a risk-adjusted report of all discharged patients, and care managers screen them and follow up. And then another said they have a care coordinator and advice nurse who call the patient within 3 business days, and also offer same-day appointments with providers. I don't know that if you got any that were different from that, but those are a lot of really good, sounds like a lot of really great things happening.
It sounds like a lot of really great things happening. And it doesn't surprise me. We have some of the lowest readmission rates for, when I look at our data, which is Medicare fee-for-service data, we have some of the lowest readmission rates in the nation. We're 4th or 5th, depending on the quarter of data that we look at. And it doesn't surprise me because it attests to the fact that we have done a really good job in the state of Oregon in figuring out how to keep our patients out of the hospital and from readmitting into the hospital and bouncing back to the emergency room. Doesn't mean it still doesn't happen, because of course it does. But we've definitely put so many processes in place to do that. You mentioned a couple things that I think would be worthy of sharing with your community at large. The risk-adjusted report that the nurse case managers take a look at, I think is a great idea. Same-day appointments is the common piece. Knowing when that patient is likely to come out and getting them in as soon as possible is huge. And the other consistent thing I heard was we get the information in front of the primary care provider. Somebody's in charge of doing that. That's what I hear time and time again from clinics who successfully do this, is that you have to get it in front of the provider because there's just so much information coming through. Somebody has to be designated to do that, and it becomes a part of their job. Thank you all for participating, and I know that the things that you've put in the chat box will be gathered up and shared with you all as well after this. Okay. So I ran onto this report. It's called Roles of Ambulatory Practices, in case you have some time and want to do some additional reading. It actually is a really very good report. It's an AMA report. It's called There and Home Again, Safely. That's the whole point of this report, is they're really focusing on safety. 5 responsibilities of ambulatory practices and high-quality care transitions. I'm going to just because it's a very long report, it's about 50 or 60 pages, I'm just going to cover the really top-level highlights because I thought it was worth sharing. So they've identified 5 responsibilities for safe care transitions. These are responsibilities of ambulatory care settings. So in this reference, it would be primarily clinics, of course, physician offices. Assessments. You need to conduct a baseline assessment of health that is comprehensive and updated on discharge from the hospital. So these things sound really basic, but when you think about all the things you're trying to do, it's one of those moments I think that I had as I looked through this, and I talked to a couple clinics about this. It's like, oh yeah, you're right, we do need to do that. So again, they sound almost elementary, but I think it was just a really good reminder. Goal setting. You need to work with the patient to establish, document, and keep up to date a set of goals and decisions in care. It's really easy as providers to build a set of goals or a plan of care, but we've got to include that patient, and if we don't, we're not going to get anywhere. Supporting self-management by providing information and resources that help the patient and caregivers to safely manage their care. So we all provide education, we all provide things around self-management, but again, you need to make sure it's really appropriate to that patient. And these are all, don't these all sound like things that primary care medical homes do on a daily basis? Medication management. There was a question about that earlier, or a comment about that earlier, and we're going to talk about that here in a bit. Medication management, communicating with the patient, the pharmacy, the family, other members of the care team to promote effective and safe use of medications. We know that adverse drug events are a primary driver of hospital readmission, ER use, and in general, complications and poor outcomes. Care coordination, helping to synchronize the efforts of all members of the care teams to best achieve the patient's goals. I think primary care is exactly where that should happen. I don't think that should be happening from the hospital or the home health or the SNF. They're a part of that process, but I really believe that the only way to be effective is to have the primary care provider doing the major portion of the coordination, because you're the only one that sees them through all settings. When they're in the hospital, they're just hospital. When they're in a skilled nursing facility, they may be seen by the medical director there. You may be seeing them as they come out for appointments. You are the only entity that sees them in every single setting of care. So medication reconciliation. This is one of my favorites, and we used to do this years ago when I was a real live nurse, and except they didn't come in brown bags. They usually ended up getting a coffee can full of pills of patients. So try a brown bag review. This, I really think, has to happen at primary care. Again, you're the only one, I've said this 2 or 3 times, that sees them in every setting of care. So try this with just a few patients and see how it works. Yeah, I'm talking PDFA here, doing a test of change. Identify a few patients to call the day before their appointment. Ask them to bring all their medications in when they come. Review each item and ask them how and when they take it and what they take it for. And then give them some documentation to the patient. So the brown bag review is much more accurate than a medication reconciliation only based on the medical record. Because you and I both know they're taking things, oftentimes, I do, take things that aren't prescribed by my physician. I take over-the-counter, I take vitamins, I take a variety of things. So do patients, particularly those with complex health needs. Consider using the teach-back method, and we have teach-back materials on our website. There's others available as well, and we'll go to that at the end of the resources. You can find materials under No Place Like Home, Oregon Campaign. That's our website, and we'll direct you to that. One of the other things that I was talking to a nurse practitioner just the other day, and she said, and remind patients to keep their medications, except when they're in a pill minder, in the original container. Too often they dump pills together, or they've got a new prescription for a drug that they were on before, they dump them together. But the problem is, first off, they may have been expired, they don't know what the oldest ones are, but the dose may change as well. So remind them to keep their medications in the original containers, no combining. I like to move things to smaller bottles, and I know patients do too. And I thought that was really good advice. So try this with 4 or 5 patients and see how it works. Designate somebody who goes through that. Even just getting a list of all the things that they're actually taking, that things are coming from other physicians or other care providers, their naturopath, their nutritional counseling person, a variety of people. Ask them to bring everything in and take a look. You might be surprised.
Hey, Stacy, a question came in. Do you have any tips on, someone said their challenge is to get patients to remember to bring all their medications in. Have you seen any tricks or heard of anything that anyone does, or maybe anyone else out there has an idea about how to help people remember to bring their medication in?
Well, I was talking to a friend of mine who's a nurse practitioner earlier this week, and they call them the day before. So I think that's, and they ask them to gather up their medications then, put them in a brown bag, and bring them. I think it's that early reminder, you know, as close to the appointment as possible. Does anybody else have any ideas on, or any successes on how they get patients to bring those medications in?
Go ahead and I'll hop in if anyone else writes in.
Okay. All right. So these are the 5 principles to guide your ambulatory practice to promote safe care. Basically, these support the 5 roles and responsibilities that the AMA set out before. And again, I think there's nothing here that you haven't heard before. But when you think of assessment, goal setting, supporting self-management, medication management, and care coordination, to be successful, they need to be person-centered, focusing on the needs and goals of that particular person, collaborative, taking advantage of all the skill sets in the team, including specialists and inpatient teams, structured, using clear and careful tools, forms, and processes, iterative, recognizing the ever-changing and evolving evolution of primary care, repeating tasks over and over, and making adjustments as the patient's needs and goals change, and flexible. Acknowledge the unique needs of each individual patient to pursue creative solutions. So again, this to me, when I read the AMA's report, it seemed like this really was the definition of a medical home and how a medical home would address these issues. Okay. So the other standard that I was asked to address was meeting 5E1, coordination and integration. It's a referral of specialty care coordination. You're required to track referrals to consulting specialty providers, include referral status, and if the consultation results have been communicated to the patient and clinicians. Is it a must-pass? No. It does have 5 points associated with it. When I read this is a big piece as far as, in my mind, implementing a program or a system or a process to track these is a pretty large piece of work. Most EHRs have some way to track referrals and specialty care coordination. However, many clinics that I've talked to still use their own tracking spreadsheets. They find it easier to use than what their EHR uses. No matter what you do, you must designate someone to be sure to check and track referrals and follow up on referral status and communication of the results. Again, if this isn't a part of somebody's daily job to check these, they're going to get missed. And it's just, again, I think it's just an example of the overwhelming amount of information that is coming at us on a daily basis. So I pulled this together, and I'm just going to walk through all the steps very quickly. Step 1, you need to improve your internal office communication. Effective communication between the physician and the referral coordinator, if that's the term you want to use, is essential to initiate the referral process. Use a simple referral form that is easy for the provider to fill out. I talked to a clinic in Southern Oregon that said they'd seen a big change in their referral process just by simplifying the form and making it very, very quick for the provider to fill out and turn in. Step 2, and this seems really obvious, but I think it's really important. Engage the patient in scheduling. You know, if you can find an opening on Tuesday, but their daughter works on Tuesdays and can't get them there, doesn't matter how great of an appointment that is. If it doesn't work for the patient, they're not going to get there. Depending on the type of appointment, you may be able to phone the specialist office and obtain an appointment before the patient leaves. In some cases, that's not able to happen either. When a patient interacts directly with the referral coordinator in arranging the date and time, we know that the likelihood of their compliance has increased significantly. If they can help to choose what will work best for them. We know that you're going to get much more compliance out of the patient. Step 3 is facilitating the appointment. After the patient has an appointment scheduled, if you're lucky enough to be able to do that right when they're there, and sometimes even before a specialist office will schedule an appointment, you've got to get the right information to flow between the primary care physician and the specialist. Again, that referral coordinator or whoever that person it is, it's been designated to do this. This is a part of their job. That will make a huge difference as well if you can get that information going back and forth. Goes back to setting up a way to communicate with your specialist office. And then here's the only one that you really need to pass your measure is track your referral results. Once the referral has been scheduled and the proper information transferred, the patient's chart goes back into the chart rack. Does anybody have chart racks anymore? Or the encounter is closed in the EHR. Many primary care offices see this as kind of the end of the referral process, but we know really it's only the first stage. After the patient sees this specialist, results should be returned to the primary care office. You might get a consult letter that is routed to the primary care physician. You might get a secure messaging with if you have that system in place. Unfortunately, if the patient fails to keep the appointment or the results of the visit are not sent to the primary care office, there's usually no obvious signal for the primary care staff to make sure that the continuity of care has not been broken. The failure is often not discovered until the patient returns to the primary care office for follow-up visits or calls to find out his or her results. So they've not gone or the results haven't been communicated, and you may not know that until they come in and want to talk to the physician about their results. In the worst case, and we've all heard stories about this, a seriously ill patient might never contact either the practice or the specialty care, assuming that no news is good news. I think we're much better at that than we used to be, but I know of I've had a couple family members that had that happen, and they just assumed they hadn't heard anything, so it was fine. And my family's full of healthcare providers. At the prodding of one of us, they reached out to their provider only to find that, yes, their mammogram did show that they had an aunt of mine that they had some issues and they needed to get that taken care of. So if a practice isn't using an EHR, or if the EHR does not have the ability to track those steps in the referral process, again, a simple spreadsheet can be used. And I've talked to several clinics that this is what they're still using because their EHR is too difficult for them, or the process, they haven't integrated it, and they're using this because they're familiar with it. Just remember that you need to, if you're going to do that, you should at least have at a minimum the patient name, the physician or clinic referred to, the diagnosis, and the date of the referral request. So then, after you do this, that's when you take a look at the data and look for improvement opportunities. Look to see how long it takes to get a particular specialist appointment or how easy it is to communicate with the specialist. I think those are really important things so that you know we always have trouble getting into this provider because there's only one of them in town, or we need to improve our communication process. That'll help you in the future. And then gather patient feedback. Ask them how it worked for them. I think that's critically important. Okay. So I talked a little bit about the No Place Like Home campaign. This is the website, and please use noplacelikehomeor.org. If you drop the OR, you end up at a quite lovely website that talks about teaching your children about sex ed at home. It's a great site, but it's not going to get you the information that you need about care transitions. In the resource section, you'll see a section on 5 key areas. We had a presentation by our pharmacist on medication reconciliation, and she talked a lot about the role of the pharmacist, particularly a community pharmacist. You can access that website anytime and those materials anytime. You'll find teach-back tools that are available in that resource section as well, and some primary care tools that we have developed. Sorry. Okay. Also on our Acumentra page, acumentra.org, There's resources for managing your health. Living Well with Chronic Illness program. There's one on specific conditions. We have 2 heart failure patient guides that are yours to use and download for free. Smoking cessation, falls prevention, managing blood pressure, medications. There's some caregiver resources. There's hospital, nursing home, and home health compare tools on our website. One of the things we don't have listed here is we do a quarterly webinar. If you're interested in how we're doing in the state on hospital readmissions, there's past ones posted up on No Place Like Home, and you're welcome to join into those. It tends to be mostly hospitals because they're interested in the hospital data, but I think primary care providers should be interested in where people are going to after they're discharged, what are readmission rates when they're going to the various settings as well, and we would welcome your participation. We also have on the Acumentor website, be a partner in your healthcare. It includes 3 questions to ask your doctor, patient decision aids, speaking up about hand washing and safety concerns. I just saw a video that said don't forget your thumbs. It was a hand washing video. I thought that was great. Avoid a return to the hospital and making your end of life wishes known. And we have quite a bit of information around hospice and home health and end-of-life issues. Questions?
So if anyone who has any questions wants to use the GoToWebinar control panel to ask those questions, we would be happy to take them now. I think one of the things in preparing this presentation that we talked about, Stacy and I did, is people who have said they've tried to engage with local hospitals, but they either can't find the right person, they have a hard time moving things forward, they don't know who to contact, or they've had struggles with competing hospitals in their local community. So I don't know, Stacy, if you want to talk about that a little bit. And then if there are any other questions, I'll organize those while you're sort of speaking to that a little bit.
Well, I think one of the most successful things we've seen is when your care transitions nurse or your nurse coordinator in your clinic develops a relationship with the discharge planners in the hospital. I think that right there is probably the closest connection that you can make to a direct information source. We've seen a couple of clinics and hospitals that have actually reached out to each other. They've had lunch together. They've sat down together and said, here's what we need. This is the best way to communicate with us. And this is what we need, and this is the best way to communicate with us. Because remember, it's two-way communication. If you have a patient that's admitting to the hospital, even if it's a planned admission, you need to get the information as the provider to the hospital so that they have the most up-to-date information. That's only going to make that hospital admission more successful. And the hospitals, as they discharge patients out, need to have somebody that they know that they're getting the information to. Hospitals are penalized for Medicare fee-for-service patients for readmissions. So if you're readmitting, if you have a patient that's readmitting within 30 days and they're Medicare fee-for-service, that's a part of the value-based purchasing plan, and they actually get penalized, and they don't get paid for that. So hospitals are really invested in not having patients bounce back into the hospital. We've seen a lot of, in some communities, we've seen a lot of work between hospitals and nursing homes and primary care to keep people from going from the hospital to a skilled nursing facility and then out and then back into the hospital. Because if they're within 30 days, they can go back into the skilled nursing facility. And we've done a lot of education in some communities across the continuum just to teach people that they don't have to go back to the hospital. Primary care provider, you don't have to send them back to the hospital. If they've come out of a skilled nursing facility, they could go back to the skilled nursing facility if they qualify. And so that communication between the discharge planners and the nurse transition, whatever term you use in your organization, I think is key.
Okay, there was one other question that came in related to the medication reconciliation conversation. And it was just someone sharing that in the past couple of months they've had their own prescriptions refilled, where 3 different medications were put in one bottle, and they were told that they look different because they're from a different manufacturer, but they're the same medication, and they were divided by a piece of cotton. And this really surprised this person. You know, they're okay with it, they're a nurse, and they understand how to use their medication, but they worry because their clients who are older adults so often know their medications by the blue pill I take in the morning at night and the yellow pill I take only in the morning. And between generic and brand names and different looking pills and different prescribers, clients can be really confused by that. So how can, you know, people get it right, and what are some ideas about how to help people get it right?
Wow, I've not heard of that, and I can't imagine anything more confusing for a patient to receive than a bottle that's separated. I mean, it might work for a healthcare provider, but the average person has a hard enough time making this work. I would hope that the discharge instructions that the pharmacist is providing are really clear. But if you're seeing that, I guess maybe telling our patients that if you ever see anything like that happen, if you ever get a bottle of pills, even if they're separated by cotton, but that have different, the same medication that looks different in the bottle, to contact you. They've got to have somebody that is willing to be responsible to say, okay, these are the same pills. I would rather that the pharmacy would even just put them in separate bottles. That seems like that would be a better idea. But they've got to have a contact where if they have questions, and I don't know that in most cases the community pharmacist would be the best place to go. I really think maybe it would be the primary care or the pharmacist if you are lucky enough to have a pharmacist in your clinic, to have them be the contact with that. But I guess if it were me, I would at least begin talking to my pharmacy to say, you know, we think this is a really bad idea. I don't know that you can affect change by doing that, but to at least be able to raise some concerns about this is a bad idea and really concerning and confusing for our patients, that might be your best approach.
Okay, so if there are any other questions, go ahead and type them into your questions pane on the control panel, and then CCSU, I know there were a couple other slides if you wanted to go through those that link to the resources like the hospital letter and other things in our last few minutes.
All right. Kate has done a really nice job of taking all of the resources that we gave her and all of the resources on their website and put them in one page that at least gives you a little bit of guidance on where to go. So the No Place Like Home campaign, and specifically there's resources for primary care providers on that page. The sample hospital agreement letter, she's got a link to that here. I've talked about that repeatedly. I was really impressed with that letter, and I've used it with a lot of adult providers and shown that as an example. The Archives of Internal Medicine report about communication discrepancies between physician and hospitalized patients. I've read that article several times because I think it really helps me to remember how difficult it is for patients to remember all of the things that they've been told while they're in the hospital. And then the exacerbation action plan and protocols, red, yellow, green sheets. Again, we have several on our website, but there's a large number of them on the PCI website. So here's also a link to the American Medical Association's, the AMA report on the There and Home Again Safely, the 5 responsibilities of ambulatory practices and high-quality care transitions. Here's the medication brown bag review from the Health Literacy of Universal Precautions for Primary Care. And again, I ran this by a friend of mine who's a nurse practitioner up at OHSU and asked her how this works for her if she's done something like this. And she uses basically the brown bag review on every one of her patients and finds that it's absolutely essential. We have another one on the patient handout, what can I do to live as well as I can with my health condition, which links patients to a variety of resources. And these are all on the Acumentor website. And how can I partner with my doctor on my health care? And I'm afraid to click on the links because it took us there, but I'm going to try this anyway. So when you go to the AcuMentor website, if you click on one of these, you'll see a variety of resources available here on a large number. Here's some heart failure pieces that we share, and some of those are also done in Spanish. They were translated into some other languages, but we updated the book and couldn't find any funding to increase the translation level. So this is how you can reach me. If you have any questions about Medicare, particularly fee-for-service Medicare, readmission rates, what our readmission rates look like in the state, programs that we have going on across the state of Oregon to help providers. If you need a connection to a hospital or skilled nursing facility and you don't know how to contact them or who to contact, I can usually put you in contact with somebody. We have several nursing home administrators that work here. They have connections across the state in a variety of nursing homes. We can connect you to corporate offices, home health as well. We have some connections there as well, particularly with the larger corporations, and I can usually put you in charge with the right person. If you don't know who the person is to contact at your hospital, who is it over quality? Who would get me to the discharge planner? I should be able to get you information on that as well. Any best practices that you want us to share with our providers and our projects and across the state, let me know. I would be happy to share those. We think that it's the best practices are typically those that come from you all. So please feel free to reach out to me at any time. My phone number and my email are right there, and you can reach me through either of those. Currently my favorite Ben Zander quote is, "A conductor of an orchestra doesn't make a sound. He depends for his power on his ability to make other people powerful." I appreciate your time and your comments and your sharing of information with me and on this presentation.
All right, so when I go ahead and end the webinar, thank you so much to Stacy for the presentation today. There are slides, and the hyperlinks on the PDF version of the slides on the website do work. So I know someone said you can't click on within the presentation, which is true, but there's a PDF on the website, and then the links are all linked from the website module as well. When I close GoToWebinar, a survey will pop up. We really ask that you take that survey and give us feedback on today's presentation. It's really helpful, and it helps us do great presentations for you in the future. Thanks again to Stacy, and I hope everyone enjoys their morning.